My name is Rebecca Seagraves, and I have a very special guest. I hardly get Dr. Jenna Seagraves online with me. Hi, how are you doing, Jenna?
I'm doing great. Thanks so much for asking. Thanks for having me.
Yeah. So we started a program, and I want to really kind of open up the conversation tonight on acute care OT and PT after birth by talking a little bit about the program that we started, but the inspiration behind it, because I think right now I'm getting a lot of traffic, a lot of questions about what can I do? How can I start this? And it's just like, wait a second. Have you actually talked with anyone who's been in these situations that we're going to talk about tonight and actually got a sense of what they're going through and why there might be even a need before you're making your list of all the things and the techniques and all the things that you could say to hospital systems and administrators and policymakers and your doctors to refer to you? And it's just like, have you talked to anyone at all about their experience? So Jenna and I are going to go back in time about 2020, I would say around September, when my dear, very, 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 very dear family from the time that we were in diapers, I want to say, was going through her first birth. And so this was before we ever even considered writing a paper, right, Jenna? Before we ever even considered creating a course to teach occupational and physical therapists how to start services in their hospital system for people after birth to receive those services. It was this experience that just upturned everything for me, right? And so I'm going to bring Miss Pamela Daniels up to our fold and just kind of talk it out and just talk about that time, what was going on. And then we'll just take it from there. Hi, Pam, how you doing?
Hi, I'm well. Thank you for having me.
Who is in your arms right now?
So this is Zakai, Mr. Zakai Jethro. The story today is not about him. It's actually about his older brother, my 2-year-old Joshua Bradley, JB. But yeah, this is Zakai, and he is 4 months old.
4 months
Going on 5 months this month.
Yes, I know. And, just to give people context, you did share Zakai's story a few months ago with Dr. Catherine Sylvester. And that's a whole nother story. If you all are tuning in, Dr. Catherine Sylvester has her own podcast through Operation Mist and was able to talk about Pam's experience with a VBAC, a vaginal birth after cesarean section with Zakai, and every which way that her medical team tried to have him delivered through C-section. So that's a whole other story that's been featured. Please go on Operation Mist, MIST. That story that Pam shared with Dr. Sylvester, and Dr. Sylvester's involvement with making sure that she had the help she needed is really incredible. But tonight we're going back to 2020.
It was really the 2020 experience that paved the way for my adamance in my 2022 experience, and just not wanting to relive my cesarean journey. I didn't know where to begin. I was quote unquote overdue. I always put that in quotes now. Overdue at least a week, and I went in on my due date. They, wanted me to stay, but I was able to speak to a homeopathic doctor who was like, "Go home." So I listened to her. That was at 40 weeks. I went home, came back 41 weeks, and they kind of immediately, through coercion, just really said I needed to have a C-section. I was past my due date. They tried an induction first that was unsuccessful. And what ended up happening was, because through that induction process, they burst my bubble, whatever you would call it. I wasn't able to go, I could, there was no other options at that point. I was stuck in procedure at that point. So this was after several days of the attempted induction. And yeah, it just 4:30 in the afternoon, they're like, it's time. And kind of just threw me in there. And, I knew nothing about children, pregnancy, let alone C-section and options and what can be done. And I honestly don't even remember what prompted me to reach out to Rebecca, because it was after everything had happened that my conversation with Dr. Seagrave, sorry,
No, Pam.
happened.
Yeah. I was about to say, come on now.
But it was after the fact that she got involved and just really helped me beyond me even knowing that I needed help, and that there were solutions to help me face what I was, set out to face. And then things got a little complicated, so I don't know where you want to go with the story. But
Well, I'm going to pause you right there, because I looked at Jenna. I got the text and it was like, help me with this section pain. Section pain. It's like, Jenna, wait, I'm now just finding out Pam had a C-section. This is how I find out with a text message. You told me you didn't even remember sending that text. You sent pictures, and then I saw the oxygen. Yeah, I saw the oxygen in your nose and like you holding JB, and it was like, oh. And so that's kind of where the story opened up for us, because Jenna, I remember talking to you. I'm like, wait a second. So she had a C-section. Because we were in the hospitals. It was the first year that you and I had worked together in a hospital setting. And we were actually working at the hospital where we were working with a team to start services after for every woman who delivered, Pam, after C-section in our hospital, we were working on that team to just get that program up and going, our first hospital. And so when you sent me that message, I'm thinking like, whoa, okay. Tell me the whole story. So I think we got on the phone, and what I want you to share, because it was one of the first things I said, I was like, what position in bed are you in? Do you remember? I could fill in, but do you remember me asking you? That was like one of the
do.
I
I remember you asking that. I spent a lot of time in that, that L position. Very painful. My son actually ended up staying in the NICU for a little time. And so, the NICU was the other end of the hallway now, long corridors, and then the other side of the door. So, I had to walk that to get to see him and, to feed him early on. So it was a lot of movement, just kind of immediately happening, where you've got this, live situation going on with you. And I know Rebecca just kept saying, you just had major surgery, And the concept of major, I don't even think I really understood the concept of what major surgery was, and so it was just a lot of new information. I had very little, probably zero prep in general for pregnancy and birth and all of that. So then it was that plus now this new reality of a C-section and induction and the C-section, because both of those were two separate but equal traumatizing factors. So.
Yeah, and I don't want to gloss over that, because honestly, you didn't realize that when they artificially ruptured your membranes, which is what that was, when they broke your bag, broke your water, you couldn't leave the hospital at that point. Most people don't realize, once you start down a certain path, once you hit that kind of point of no return, you're going to see this through, right? So they artificially ruptured your membranes. You had already had probably an uncomfortable experience with the induction. And at that time, I think that people really also should remember, you didn't have a lot of traffic in you didn't have support that could stay with you the whole time.
Right. It was during COVID. I had my best friend, who happened to be pregnant at the same time, was there for the first couple of days, and then she had to, leave, and then it was just me and the medical team.
Yes, and so because JB was in the NICU, you were in an L-shaped bed, because it was the easiest way to get in and out and walk down to the other end 4 corridors down to the NICU, no wheelchair. You weren't having anyone wheel you down. It was just you in the hospital by yourself, going to the NICU as often as you could to visit your son after a C-section that you weren't even expecting. I mean, how many, like, could we add anything more, right, to that experience? And then people are emailing me today, what can I do to start this program? And I'm like, talk to somebody, talk to Pam. Pam, what did I like? And we talked a lot about the PT that eventually we got to come into your room. Do you remember that experience of just even getting a physical therapist in your room?
Yeah, I remember you asking me some questions, initially about like, well, is there a physical therapist there? And, so I started asking those questions to the staff members. And I just remember everyone looking at me like I had two heads. And I knew, when you were explaining to me what help I could get if I had the physical therapist there, I'm like, well, yeah, that would be really helpful. So I just remember initially, trying to asking the questions, getting, the blank stares, and we'll find out what we can find out from the staff. And then all of a sudden, Rebecca was on the phone with the hospital and making stuff happen. So it was my part was small in that regard.
Your part, honestly, is the only part that mattered, because you had to put me on speakerphone. I remember either a doctor or a nurse was in the room and I started talking, and then I'm like, there was silence, and I was like, Pam, what's going on? They're like,
they're looking at each other, trying to understand, like, why is this necessary? And I'm giving these very clinical answers, as to why this is necessary. And they're like, wait, what? Okay, I guess that is logical.
Yeah.
So, and that's why eventually they did approve, for the PT professional to come up and help me.
Right. All right. So Jenna,
who you trained on the fly.
Trained on the fly. I actually trained this PT over the phone. But before we get into that, this is important. This is an important part of the story. Jenna, if you now could kind of give people some context, right? Because a lot of people even watching this are still not going to, like, we're naming all the obvious things to us. Pam had a first-time baby, was alone in the hospital, was going down 4 corridors to the other end of her unit, wherever the NICU was, to see her baby, getting in and out of bed, being in an L shape. I got on the phone with the physical therapist of that hospital. And believe me, like, that is not easy to call a hospital, get routed to the rehabilitation unit that you don't have like any business calling from outside the hospital, and speak with the very person who was sitting on the order, not about to see Pam. And she even told me that over the phone. She was like, yeah, I got that this morning. I was just going to disregard it.
She was going to blow it off. Yeah.
Like, so from your standpoint, that might be enough for me and you to like see Pam, but for people who are watching this, they still are like, well, why does she need physical therapy? It sounds like she was getting out of bed, going down to the NICU.
Yeah. Oh, go ahead, Pam.
No, go ahead.
No, I mean, yeah, I think that's a huge barrier that we see a lot of times, even with our own field, even with other physical therapists, that they hear that the patient's they're getting up, they're actually walking in the hallway. They're doing it independently. They don't have any, they don't need any assistance for that. But the most important thing really, I think, is being able to simulate the home environment as much as possible, and just knowing that, is that the type of bed that Pam will have at home? Is that the way that she will be able to be positioned for long periods of time when she's at home? No, likely not. And we see people after just general abdominal surgeries all the time to go over these, I hate to say like very basic concepts, but that's how it feels, I think, for a lot of physical therapists. But it's not basic, and it's not common knowledge to every individual, just to every person. And I think another big area that we're all kind of glossing over here is the amount of pain that Pam was experiencing as well. And that just seems like it wasn't even being addressed. And I think we can all agree that we're pretty good at being able to help people find positions that can relieve some of that pain and discomfort. and provide some simple stretches, some simple things to help make sure that you're feeling good, but that you're also allowing your body to get rid of that extra swelling that always happens around any type of incision site. So those are just some of the things that immediately come to mind. I could continue and we could derail for an hour if you wanted, but
Pam, I promised you only 10 minutes, okay?
Well, I just kind of wanted
promise-
to
Yeah,
to echo somewhat what Jenna just said, because I think the word that gets used a lot is discomfort, but that doesn't really translate to understanding like the dynamic problem that is taking care of the baby and trying to take care of yourself. Like the idea of trying to take care of yourself is just like doesn't exist because you're concentrating on the baby, right? And yeah, it's just it got real when I got home, right? When you get home and you think you can just pop up and go do this and go, and it just your reaction time to what your brain thinks it's about to do versus what your body is able to do, is a huge, huge disconnect and huge setback. And just realizing like I needed to review again how I'm supposed to get out of this bed once I'm home. Because I'm like, okay, now what was the and even breastfeeding. I mean, breastfeeding became like a real huge challenge for me because just I couldn't find a position that worked, like to be able to support, him properly and feed. So like I feel like I that was like a major reason why I stopped as early as I did. And again, why I was fighting for my VBAC when the time came, because I just knew that the learning curve I had with one child was not going to exist with a second. And so it's just, I just don't know how these options are not part of the standard care. And which was there's just so much that's not a part of the standard care that, I realized, especially this time around, that, educating myself so much more would help me make better decisions. And regardless of if you're going for a C-section or you're going for a natural birth, it's just the more information and support that you have, the easier it is for you to at least try to plan for the things that you can control. So
and we get a lot of like pushback because it's like we don't want to overwhelm the mom, and we're told that, well, we don't want to give you too much information. But right now, where you are right now, you're holding Zakai in your arms. You're still breastfeeding him. And how old is he?
4 months, going on 5.
JB, who you had by a cesarean section, when did you stop breastfeeding? Do you remember?
I mean, it was somewhere between like the 2 and 3 month mark.
2 and 3 months. Because I remember you saying like it was the pain. It was too painful, right?
Yeah, it just physically. And then I got an infection, in my surgical area. So that whole healing journey, in and of itself, like that process was painful, but then having to come back from that just really affected, my ability to properly nurse.
I remember in the first 3 weeks, you were in the wound care, like you were getting treated basically for the incision opening up, right? And
yeah.
And so I want to go back really quick to the hospital, because I think this is an important point off of what Jenna was saying. She said a lot of like simulate the home environment. The first conversation, right, that I had with the PT, because we actually talked a couple times, the PT ended up seeing you twice, which again, I'm getting a lot of like requests, people emailing me, well, how long should I be seeing someone? What's the duration of the session? Like all these questions that I don't think really an acute care OT or PT should be asking. Like, think about if somebody has a home situation where they have stairs at home, they don't have support. At that time, you were thinking you were going to drive yourself home and carry JB up the stairs. Right? You were telling me all kinds of stuff where I was like, Pam, don't leave the hospital. Don't go anywhere until I get your team on board. But you have about a good like set of steps. You have all concrete steps going up to your home. And I had to explain to the PT, because I explained your situation. And she said to me, I'll never forget this, well, what do you want me to do? And I said, I took a deep breath because I'm like, if I lose this call, I'm losing the opportunity for her to work with you. So I was very nice. I'm nothing like I am now. So, so I said, I would at least focus on log roll, right? I would at least focus on you being able to get out of bed that's flat without any handrails. And then it kind of like hit her. And I think because she got in the room with you, she was able to see everything else. So I think the point really that I want everyone to take away from this conversation, Pam, and you already said it, you don't understand how this is not standard of care. But from my standpoint, I don't understand what people are not seeing. And it just hit me that they're not talking to enough people. They're not hearing these stories. I can't keep having these conversations that are circular, talking to OTs and PTs that are in our field about the same thing every single month, and they're still not talking to people like you.
No, absolutely. I mean, I have quite a few friends who are all, having babies around the same time, and the majority of them have had C-sections and complications, from that. And it's just, the fact that most of the women I speak to, when I tell them that I had a VBAC, right, like they didn't know that they were allowed to have a VBAC. So it's just there's misinformation and then there's non-information, just not knowing that there are these other avenues and these options. So yeah, this is very critical information.
I would say, yeah, the misinformation is that you can have a VBAC. That's the big misinformation right there. Right. And then the non-information of just, well, what does it take? What does it really take to get to that point? And that's, again, a story that I want people to know very, very sincerely. I even think that we have Dr. Sylvester. I'm one to pull people up into the audience. If you guys have not been live with me, if she is here, I'm going to have to search for her. But that is just a story that I definitely want you to go to her podcast. It's Operation Mist, and it's on YouTube as well, where she featured Pam's story about her VBAC. So that's one to see. And I'm wondering if I think I see you, Dr. Sylvester. May I pull you up just to say hi? Ooh.
Hey, beautiful girl. I've been live in this chat. You change the game when it comes to PT, OT's role. And it is this conversations like this that allow us to know, the necessity of what we do. And the other Dr. Seagraves, Jenna, I love how you just simply put what we can do to help. And Pam, hats off to you, girl. You are so strong, so resilient. I think that a part of your story that really does need to be highlighted is you being willing to speak up for yourself, because we cannot be empowered if the patient is not willing. And it does take courage to be like, hey, I'm putting someone on speakerphone. I need you guys to talk to them, because at the end of the day, when we hang up with you, you're the only one left in the room. So thank you for, I feel like, bringing out all the roles and the teamwork that it takes to make this happen. And then one thing I would like to say, Dr. Seagraves, is, how, you had to consult with the PT that's in the hospital. If that's what we have to do in this phase, then that's what we do, right? We just make sure that the person who is in there has the information that they need. And it may be frustrating for a time, but at least they're the ones there that are doing the work. And so if we have to fill in those knowledge gaps, then that's where we are right now. And it's really good that you were willing to do that, because what I think people don't realize is we're putting our licenses on the line sometimes, right, to have those consultations, but it's worth it because Pam is here and she's in a situation where she was able to have a vaginal birth afterwards. But can you imagine the people who go through that traumatic experience the first time? Sometimes they're not even in a position, in a headspace where they feel like they can get pregnant again. So I'm just grateful that you brought her on so that we could hear her story, because I think that's what's going to inspire more PTs to be like, you know what, I can be in labor and delivery, even if it's just teaching the log roll, the pain management piece, the edema management piece. We can do that. We're trained to do that. So thank you.
Absolutely. And labor and delivery. So not just postpartum recovery, but you said labor and delivery. Catherine, Dr.
Yeah.
Sylvester. And that's a huge piece as well. I think after that experience, I knew how important it was to talk to that PT, to at least have her in the room. And then once she was in the room, didn't have to say anything anymore. She saw it. But what got Pam to this point, I don't want to like gloss over that. I do want people to watch that episode that she did with you to get her to this point where she was able to have the birth that she wanted. That's the missing piece. And I think that I'll go through waves where I see the work is really important, but then I'm thinking, but it's still after the fact. How about if we were in labor and delivery? How about if we were actually providing information that people needed so they know, oh, once my waters are ruptured, I know that my opportunities are limited. So maybe I can choose differently if I know all of my choices. And that's the non-information I think Pam just mentioned. People are not being given the information they need to really make informed choices, right?
I just want to add, like, I have my best friend who's right now pregnant with her fourth child. This is her fourth C-section. And there is nothing happened to her medically on any of those births that made that requirement, just other than the size of the baby. And her third one, no, the second one was technically premature, like a week, and it was still a C-section for no medical reason. So it's just the culture shift that's
the baby
needed.
that's in your arms right now, wasn't he said to have been
he
like
as we got closer
enormous,
to the due date, he went from like maybe 7 pounds to maybe 8 pounds to like I think he's gonna be 11 pounds, and it's like, okay, so between that and the shoulder dystocia, those are the two things they just kept dangling in front of me to say you need a C-section because he's going to be too big, he's going to run the risk of shoulder dystocia, don't you want to do what's best for your baby, but no other medical fact occurred what was happening or was in play that would make sense for us not to just give it more time, see what happens.
And Pam, how much did he weigh when he came out?
He was 8 pounds 6 ounces.
Yeah, so not 11.
No, definitely not an 11 pounder.
Wow.
And your placenta was fine as well, wasn't calcified?
Yes, my placenta was okay. It was intact. My water didn't break. It didn't. I had liquid in there. That was the other thing they kept saying. I was all dried out. Baby had no water left in there. I mean, there was a lot of
that's a traumatic
scare tactics. Yeah.
That's the trauma of just being in the hospital and being told all those things and then getting through that. So Pam, you'll never trust me again because I went from 10 minutes to 27.
It's all right. It's all right. I'm happy to share. This is such important work. Like I said, I know too many women who just don't have this information and who aren't with providers who care to have this information. So you ladies are front line here. Okay, and this is a battle for sure. There's gonna be more babies coming, this isn't gonna roll back, right? This is something that really just has to be systemically improved. So thank you
for sharing your story.
Thank you, Pam.
All right. Thank you, Dr. Sylvester. I might even call you back up, okay? So don't go anywhere. Wow. All right. So Jenna, let's just kind of come back, okay? Right to
Okay.
where,
Okay.
because I mean, honestly, after that with Pam, you and I wrote the first paper, and then we
Yes.
didn't really, I mean, it was months before we started talking seriously about like even creating a course, teaching the first round of OTs and PTs to do what, I essentially taught that PT over the phone to do with Pam. And so we really just joined forces at that point, but then it didn't really start to pick up until I think the move to Colorado, where you had some you had some stories that I was just like, we're
Some
not,
stories.
we're not teaching, like we're not actually getting into what people coin now as the social determinants of health. You know, that's, what is that, first of all? I feel like I'm hearing that all the time. And what Pam already told us, I'm already thinking like, well, that's obvious now. Why does it feel like it's just a new term, right? When we should have already
Right.
been looking at those things. What does
Right.
that mean? Tell people.
Oh, well, yeah. So social determinants of health include a lot of different things. So it can be related to access to healthcare, whether they live in a rural community, an urban community. Do they have any trouble with food security? What's their health literacy? Like, there's a bunch of different factors that I could go on and on about. But I think there has been quite a bit of research that's come out fairly recently, which may be why it's more of a hot topic now, that has shown that a lot of these more chronic or preventable conditions that come about really are stemming from issues in social determinants of health. So problems in that area that aren't being addressed. And so I kind of say that to lead into why I really enjoy working in the hospital. I think in acute care, we have the ability to ask those questions. You know, we're not just looking at a patient's mobility, but we assess the entire picture. So everything about that patient, what is their environment like at home? Do they have support? Are they worried about going to the baby's first pediatrician visit? Is that a concern? Do they have a car? You know, how are they going to get there? So we actually get a deeper dive into what does the picture really look like for once they leave here. And because it's a hospital setting and we have a huge multidisciplinary team involved, if there are any red flags, you know, we can quickly make that referral process to social work, case management. Sometimes we've actually been making referrals to behavioral health advocates, and so it's something that I just think can be so empowering, and it's something that we do for any patient with any diagnosis, any condition, and we're all there's just so many things that I think we could help with just from that standpoint alone.
We didn't even touch on this.
Yeah,
Like,
go ahead.
well, P didn't even touch on this, and I meant to ask her, but Pam had to go back to work fairly quickly. But she was planning to. She was planning to go back to work.
Mm-hmm.
And like soon, it was like at least within the first 4 weeks, she was already talking like, you know, what do you think about me, you know, just going to the office, right? And it's like, we wait 6 weeks, right, for OBGYN to see moms and kind of sign off. But there are women that we've come across who have to continue being the breadwinners. And yet, as OTs and PTs, we know to ask those questions, but I don't even think that when I'm thinking of social determinants of health, are we as maternal care team providers asking about someone who has no other support other than their ability to return to work, support their family? Are they single parents? You know, not just the home environment piece, but what they're going to be doing in their home. And that's where I started to, I think the shift happened for me was if we're not going to do it as PTs because they're already up and walking and there's all these barriers, bringing OT on to me made the most sense. For me, having an occupational therapist in the room to recognize what that person's desire was in terms of performing the occupations that they were going to perform, returning back to their environment, doing all those things that they needed to do. If we could actually get that person on the team, I think that deeper dive, you know, into their social determinants of health, that would just make more sense for them to just be on every maternal care team. So I've stopped, you know, I would love for both disciplines to be involved, but for me, OT became more of the necessity. It became more of the obvious, like get them on the maternal care team and they can route that person to where they needed to go, to the modifications they needed at home. We were having moms that were home who were collapsing essentially, right? Because they couldn't shower. They had lost so much blood. And when they were in their own environment, they could not actually just handle the demand of taking a shower, right? And they were being readmitted back to the hospital. So to me, the fact that we don't even have an occupational therapist to really truly do a deep dive into a person's environment and their support system and the activities, the occupations they'll be doing at home, that to me was the greatest disservice. So I would love to actually invite an occupational therapist in the room who's actively treating patients in their hospital, right? People, women after birth in their hospital, to this conversation, and just to kind of get a better sense of what they're doing. But would you add anything to that of even working with OTs in this way with this population, Jenna?
I love occupational therapists. I think that they are crucial to work with this population for all the reasons you just said. They, and then to add to it, they also look at mental health. That is, they get extensive training in that. And so I think that we can't deny the fact that postpartum depression and anxiety, that is a real thing, and it affects a lot of people, and it can happen really throughout any phase, pregnancy and postpartum up to the first year. So that is something that needs to be addressed and screened for, I think, a little bit more rigorously than how it is now being done. I think they asked 2 questions. I could be wrong, don't quote me on that. But occupational therapists will spend that extra time too. And I think I can't stress enough what I love about just our profession as therapists, physical, occupational, even speech, or just all of therapy. We spend time with people, and that is extremely valuable. I have a story that I could share about a patient that really came from it. Her home situation was nothing actually her entire situation. I'll just say her entire situation was nothing at all the way that I expected it to be. If we have time for that.
Save that. I do want to
Save it?
actually,
Okay,
yes,
okay, I'll
save
wait.
that. I want to welcome Dr. Pamela Hess. Thank you so much for joining this conversation. Occupational therapy, I do want you to weigh in on Jenna's story, because I think if she actually just shared it with you and you can hear why this conversation is so important and centered around people. We're talking about people, not talking about policies and procedures and all of that. We're talking about people. And so, Pamela, welcome. Another Pamela.
Hi, thank you. I first of all, I thank you. I can't believe how many people are on this call, and it's so empowering and exciting, and that people are doing this work. I really appreciate you touching on the mental health aspect of this, because when I walk into a patient's room, especially postpartum, it's almost like the first thing that comes on my radar is I'm scoping out the room, who's in the room, how is my patient looking in the bed, who's in the bed with her, and then mostly importantly, the first thing I ask is, how are you doing? And my focus is laser zeroed in on the mom. So one of the things that I've been really trying to focus on, and we just actually went through at my hospital that I work at, I actually am an outpatient. Believe it or not, I'm a pelvic floor therapist. As an OT, I'm the only OT and as a pelvic floor therapist, but I do go up on the postpartum floor, and I screen the patients for mental health. Not that educate them, but that's part of our protocol. We just went through a training with our PTs about how they can do the screening as well. And if they needed to go ahead and refer, then at least we have a protocol now in place of how that's going to happen. So that to me is just as important as what I look at and what she's, how she's doing, both physically, emotionally, and of course, spiritually. And I'm not talking about faith, even if she is, but I also just talk about the whole person. So I love the collaboration between my PT friends and my OTs, but like I said, I'm sort of a lone soldier out there, but I have a lot of good support too.
Awesome. I wanted Jenna to just hold on her story, because we often are speaking for our OT colleagues. So for you to be the lone wolf, I'm like, listen, if we can at least just have a presence where an OT can tell the world what they do rather than us speak for them, really, I think the big gap here is that I have seen the value of OT, back when we started, even before that story with Pam, when we were starting program services, we were asking for OT to be more involved because we were getting pushback as PTs. And so Jenna has a story, and I would love for you to hear it, Pamela. This wasn't planned, right? So you haven't heard this before, but to give your insight on what you would have approached as an OT, I think would be valuable for you to hear.
Okay. So, some background here on this situation. So this was a patient, it was her 4th C-section, and it was a planned C-section. So had it before, wanted to just kind of go down that route again. And this was before we had automatic orders for anyone after a C-section. So I say that because I had to try to fight to get into the room in the first place. And I had pushback from the physician who was saying this is her 4th C-section. She's been through this before. She knows what to expect. I don't think that there's anything you can do for her. And, I just kindly explained what it is that I could offer, and said that it's ultimately up to the patient. I would like to offer my services, and the patient has every right to refuse. I don't have to see this patient or bill for my services if she doesn't feel she needs it. And he liked that answer. So the order was put in. I enter the room and it's completely dark. The room is completely dark. The infant is in like an incubator with a blue light on the baby, and the mom is just laying on her side in the bed and not wanting to leave the room ever. She's very anxious. You can just feel it. And she's also in a lot of pain. So I'm going to just start by saying that. I'm going to give a little snippet, and I just want to hear from you now, Pamela. What would be kind of going through your mind if you came across that? Just curious. I can give more background too.
Yeah.
If you
which
feel
way
you need it,
which way was the mom facing? Just curious if you remember.
towards the door.
Away from
or
baby?
she's no. She's very much looking at the baby, very concerned about the light situation. She's scared. She's never had a child who needed this. For those that don't know, it's a way to oh goodness, what is it? It just left me.
For jaundice.
Thank you, Rebecca. Yeah. Yes. So it's to treat the baby for jaundice, and so she's never had that before, and she's really scared about that.
Phototherapy. Yeah.
No, I think the first thing that comes to mind is there's something, like, to me, I think about the nervous system. There's something that's out of place. She's obviously, like you said, scared. I don't know her story. I think there's some trauma that might have happened. And my first concern would be her, like, what's going on? I want to hear her story. I want to hear what's going on and how she's feeling. And even if just providing some space where she could maybe start talking, that would be the first thing I would do. Approach her very gently, and I just want her to know that I'm a safe person, and that, because I think that I can't figure out like what it would be. Like, I'm just envisioning myself in that room right now, and I just want her to know that I'm here for her, and I don't care what it is, but I want to be here for her, and I want her to know that. And yeah, so that's how I would approach the room.
That's perfect. That was a perfect answer, Pamela. Thank you so much for just sharing that. Really, I think it's so important to know, because this is a person. Rebecca said that we're treating people, and I think a lot of therapists who work in the hospital sometimes kind of get productivity in their mind. They feel like I got to get in, got to do my eval, get out, bill, move on to the next patient. And it's like, you come in the room and whoa, I think we need to take a moment here. And I really appreciate everything you said. I mean, spot on. And just, that's a beautiful way to handle that situation. Create that space, allow the patient to share if there is anything that they would like to share, and sometimes they don't. Sometimes, no, I really don't want to talk. Okay, I'm not going to push you, but having that door open can be so helpful. So I'll give a little bit more to the story. So now when I come in, I see that she has a wound vac. So it was the fourth C-section. And so I think we can all appreciate that the more times we have to reopen an incision repetitively, that soft tissue is not, it's never as strong as it once was. So it's getting weaker and weaker each time. So it did require some foam packing and a wound vac. So she's never had that before either. So she has this big old thing that she has to lug around with her that's attached to her body. And she has a child that has jaundice and is under these lights. She doesn't know that it's okay to turn on the other lights, that as long as the baby is under its own lights, that, you know, it's okay. But she was so scared if she turned on any lights, it would interfere with the treatment. And so it was just that moment of letting her get everything out. What are all the things you're feeling? Tell me everything. And now I can step in and give some of that education that, you know, baby's okay, baby's under the lights, and that's where baby needs to be right now. We can have other lights on, we can open the blinds, you know, we can let some sunlight in. And this wound vac, you need it right now, but I have some other things that we can try that will further help improve the wound healing and help your pain, because she was in pain too. And she had never heard of an abdominal binder. This is her fourth child, fourth C-section, and she had never heard of one. No one had ever educated her on that. Her and her family had just moved to the area, so they were brand new. They didn't have any furniture. Like all of this I have no idea of any of this when I come into the room. So I first walk into a pitch black room, and as she's talking and telling me all of this, she's telling me the home situation. She lives on a third floor apartment, no elevator, sorry. So it's stairs. She is her fourth child. So she's very concerned about how is she going to take care of her other children and this newborn. She has a 1-year-old, she's still breastfeeding. So how will I breastfeed both? You know, these were all her questions that she hadn't asked anyone else because no one thought to ask her how she was doing. And let's see what else. So we get the binder on, and it just really helps her pain. But so I decide to handle that by just taking time to focus on that anxiety piece. And we spend a good chunk just doing some diaphragmatic breathing, having her lie fully on her back, get her, everything you said, her nervous system, right? Kind of calm it down a little bit before we do anything else. And, you know, Rebecca had brought up that sometimes the mother is the breadwinner and needs to get back to work pretty early. So that was one of the first questions she asked, is that she is a manager at a pizza chain and needs to get back as quickly as she can. She was only planning to take a few weeks off because that's all she ever needed in her previous, but now she had a wound vac and she had all these other complications. And she's asking me, when can I go back to work? Which requires her to stand. So she is still making pizzas and things like that. So standing, reaching, they have lots of financial concerns. And then the extra piece. So they moved recently and they have no furniture. She's sleeping on an air mattress.
So I have a question. So Pamela, we opened up with just a dark room and phototherapy. Jenna comes in with a dump truck, right? Because to be fair, no, don't be apologetic, because the doctor, to be fair, said, I don't think she needs your services. So Jenna had no idea of everything that she just dumped right there. And so when we're trying to advocate for OT services, could you just provide us some insight after being given even more information? How would an OT, or what could an OT evaluate or do or intervene in all of that social history information that you just heard?
Oh my gosh, like where do you begin? Oh my gosh. I mean, you know, one of the things about our scope of practice, and again, it is, we are constantly working to help people get back to doing what is meaningful to them, right? That's really the home run pitch. But it's everything that an occupation, meaning how we spend our time. I mean, you've just laid out so much. She's got 4 co-occupations. I would say 5 co-occupations now. She has 4 children and the occupation of taking care of herself. first and foremost. So addressing those needs and how she's going to manage that role transition once again as a mother, is that what we can do is provide, like you said, education or adaptive strategies that maybe perhaps that won't put her in some pain, that she can still be as independent and also provide for her family. So that's the thing. Is I think the other thing is the home environment evaluations, like looking at our home, not necessarily we going to her home, we can, but I would definitely continue to kind of pull back the veil a little bit more of like, let me know more about your home setup. And of course, if she doesn't have any furniture, then the next thing I would do is be advocating for my patient of who can we call that in the community that might be able to provide furniture for her. I mean, there's a lot of churches or people that have things like that we can, even social work should be able to provide those things. And then the other thing is just even that self-care, like the self-care stuff, how she's going to manage, cleaning herself, her sleep hygiene. That's the other thing that we address. And I even would be curious about, who's going to be helping with her meals. Like, where's her meals coming from? Like, who's going to help her with that, and who's going to provide for her family? She's can't go grocery shopping right away. Who's going to be bringing the food to her? So those are like the things that I'm starting to think about as well. And then just simple dressing. I love the fact that, thank God that you actually brought up the whole abdominal binder, but that's like, to me, it's like C-section 101. And I don't understand. I'll walk into a patient's room and they're not there. And so I go running around the hospital looking for, I think there's one up on the other floor. I'm like, why are these so, I don't know, scarce? It should be like an automatic for these moms. But those are the things that start coming to my head a little bit. But yes, we really focus on getting that person back to where they were prior level function, but what's really meaningful to them. Like, I would continue to ask her, well, what do you want? What is your therapeutic goal? What is it that you want to work on? And then start from there. Does that answer your question?
It answers my question like abundantly. Thank you.
Okay.
Yes, really. And thank you for being brave for me to pull you into this conversation. But I think it's just important. I'll say this to you, right? And you can respond. But I think it's important that we meet people exactly where they are. And to do that, we have to learn their story. We have to be intimate with the environment that they're going to be intimate with in order to provide the resources that they want and they need, not what we want or think they need. And I think that initial reaction to Jenna wanting to provide services from the doctor, I think that would have been enough to stop people from going into the room. I think that's the point of this conversation tonight. How many of you, if you're in the audience, go ahead and chime in, would that doctor's response have stopped you from going into the room? And be honest. Like, there's no judgment here, because obviously if we all could, from this conversation alone, we would probably, starting these programs and in and beyond the hospitals that we have worked in and Dr. Hess works in now. But really and truly, if you work in a hospital that offers maternity care services, and a doctor says to you, this person knows what she's doing, she's fine, she's had 4 C-sections, she doesn't really need your services, would that have been enough to stop you right then and there? And it's okay if it is. That's why we're having this conversation. And so I want to thank you so much, Pamela, for joining us tonight. And then now open it up to just one more. I'm going to bring back a previous guest that Jenna and I have had on. She joined us at the beginning. But if Dr. Sylvester, if you're still in the room, I would love to just have you on for one more moment to really talk about everything that we've talked about tonight and kind of like bring this full circle on some other things that therapists can consider. So even beyond social determinants of health, Jenna, you and I have talked about this quite a bit. The things that we need to really be looking at now, more than we probably have emphasized in the past, has been people's ability to tolerate now the environment that they're going home into. So yes, we can consider, the support that they need, the resources that they need, but also are they able to tolerate that environment, and what can we be doing differently? So I want to just bring Dr. Sylvester one more time to the stage to just chime in, because last month we were graced with your presence of giving a webinar that is now live. It's called Protect Their Hearts. And you gave such a deep dive into the cardiac measures and just the overall response that the body is actually going through. I think you mentioned it that, and correct me if I'm wrong, the heart rate can climb up to 195 beats per minute during labor and delivery, right? And so we're thinking of the people who are pregnant, who we don't want to, necessarily overextend them, but are we even preparing them for this labor and this birth experience? And then also for the recovery afterwards. Can you just kind of bring this full circle as to what OTs and PTs, if you can just recap, what could we be doing in the hospital?
So first of all, I would like to say, when you said, would it stop you from going in? When I used to work in a hospital, I would wait till I clocked out, and then I would go and see people that I knew were having babies and just do their therapy with them. And I'm telling you, there have been so many people who have reached out, like, it saved my life. I had so much less pain. Had a girl reach out because she was crying on the floor for days at home in pain. And she remembered that with her first birth, I snuck into her hospital room. So she was like, maybe I could just call her this second time around. And it's like, we know what we're doing. And we know more than they know. Let me just say that. So even if we don't know exactly what we're doing, we know more than moms know, who are not healthcare providers. And so if we're not going to be invited in, we just have to go sometimes, And so I would like to say, not just when we're in the hospital, because, I believe between pregnancies, preconception, people are coming in third trimester into our outpatient clinic sometimes, right? And so we can start preparing them then. But when women come in the hospital, we have got to look at their vital signs, and we have got to stress them in a way that they're going to be stressed at home, understanding that it's better for them to be stressed with us in the hospital than for them to go home and then do those 3 flights on their own. Because if we can document that something is awry with their vital signs, it's less likely that they'll be sent home by themselves. And so just recently, I was telling Dr. Seagrace, one of my moms delivered, and, she was trying to get PT, OT, whatever. And, of course, they're just telling her, you're healthy, you're fine, you're doing good. And so she did her own stress test. She got up, walked around the room, started prepping to get into into the shower, because they were trying to send her home. And of course, as soon as the nurses walked in to take her blood pressure, they were able to take it after she had been moving around. So she didn't need a PT physically in the room. She needed to know, I need to know this information because I'm going home and my blood pressure has already increased a little bit while I was here. And it's just a matter of us watching the vitals that need to be watched, because for women, they're dying from infection, bleeding too much following delivery, and cardiac issues. And as PTs, we know how to monitor all of that. And so if we can teach them, look, when you go home, make sure you're monitoring your temperature. And then if it's a certain amount, reach out to your provider, monitor your heart rate, because what we're finding is within that first week following delivery, the mom is taking, when y'all talked about being the sole breadwinner, they're also the ones running the babies to and from the well baby visits, right? And so imagine a person who hemorrhages and then they go home, and now they're still moving around just like someone who has a regular hemoglobin level. So just knowing that hemoglobin levels drop during pregnancy, and then after they deliver, you lose a little bit more blood. Then you think about that person who's hemorrhaged, who loses even more blood. Now they're walking around with a hemoglobin of possibly 8 or 7, and they're used to being at 14 or 15. And yet their responsibilities, their mobility is higher than it was pre-pregnancy, because now they have a little person to take care of. So just making them mindful of that and helping them understand that oxygen, right? Everyone understands the importance of oxygen. So if you just tell them, look, your body is functioning on about 40% of what or 60% of what it was functioning on before you had this baby. So think about that. Can you reduce the activity levels that you're doing by about 40%? Can somebody else drive you to and from those well baby visits, or come and help take care of your house and things like that? So I think as PTs, OTs, we can be teaching them who can be your village if you don't have one? Pamela, I love when you said, there are churches and people that can donate furniture and things like that. There are also churches who will do meal runs. So they'll have people come and drop food off. But as a mom, sometimes it's hard to ask for that help. But if you have a provider who sets it up for you, you're not going to be like, no, I don't want anybody to come. No, bring me the food, right? It is hard. It expends a lot of energy. And I know that in your course, Dr. Seagraves, you talk about METs. And OTs are the queens and kings of monitoring METs, and letting people know that you taking a shower is a job. And so just understanding that if you get tired, that's okay. We have to send them home with the equipment that they need. If there is nothing else that we can do, we provide them with resources, we provide them with equipment. No, we don't want them sitting for every shower, but they have to understand that they can sit for a portion of their shower, and then they can monitor their heart rates. A lot of people, even if they never use their smart devices, they can check a heart rate using their smart device. And we can let them know, look, if your heart rate gets up to whatever is calculated for their specific norm, then they can sit down and rest. So it doesn't have to be that a provider is there all the time, but if we can give them metrics to look for so that they know, when do I call back? When do I take a rest? We can give them a bedside commode and then be like, hey, walk halfway to the bathroom. If you don't have to necessarily transfer to the bedside commode because you have a little bit more endurance, then set it up halfway. Walk there, sit down, use it, take a rest, then stand back up, walk to the bathroom, empty it, take a rest. Like, then it becomes normalized. And I think part of our job is letting them know that women don't give birth and then they're back at 100%, right? It's that they can give themselves grace. So even if we can't be in there more than one time, we can give them more information than they had if we hadn't walked in that one time.
Wow. Wow.
I could listen to you all night.
Right? I say, Jenna, we just sit on the couch and talk about Dr. Sylvester. We can literally listen to you all night. We really can. We really can. Please really check out her webinar. It's so packed full of information that, I rewatched it again and again and again, Dr. Sylvester, because I really can just see, when you're explaining all of that, I can see, oh my goodness, what have we been doing? What have we been doing? That makes so much sense. Especially when, and Jenna, we just talked about this recently with postpartum hemorrhage. What are the tissues not getting? They're not getting oxygen, right? Right? Dr. Sylvester, so thank you so much. Dr. Hess, would you like to close out anything from just a voice from the OT side of things after that?
Oh, I love this. I can't believe I was like, oh, I don't know if I'm going to do this or not. And I'm so happy I jumped on, and I just feel like this really is a collaborative approach. And I think one of the things I always try to focus on and end with my sessions with my patients is in a sense of empowerment. And that's always been my goal for my patients. And I'm now looking at all these names and these faces on this beautiful screen. I just want to empower you all to be the best you can be, and empower your patients, empower each other. And I'm here, I'm accessible. If you guys ever want to reach out, you're welcome to reach out. But thank you so much, and continue to do amazing things, everybody. I love it.
Thank you. Thank you to you both. Thank you so much. So, Jenna, I have a call to action, because I think even after hearing, what they both said, right, I realized that you and I would not have been able to start this work, would not have been able to find this amazing team of people, even come across Ann Krogan and see what she was doing in Colorado, meet Erin Licati, who also started a program. I believe she's on there, and she also has a webinar that really debunks a lot of the myths that this service has cost barriers, that there's too many barriers to putting a program like this in place in every hospital. And so I do want, to give her a shout out and thank her for giving that information about reimbursement and how it's actually costing us more to have more moms go home sick or have complications or have to be readmitted to the hospital. It's actually costing us way more. And for acute care therapists to not be on the maternal care team, I think this conversation will become null and void in our lifetime. I really do. But there was a theme tonight, and this is a call to action that I want to leave, like we did in our first paper, is that for people who want to start these programs, Catherine even said it, she ended with this. She would clock out as an acute care therapist and go into patients' rooms on the maternity unit. First of all, I don't even know how she was badged in. Like, we have to be badged in on that unit, do we not? Like, we have to know to be in there. So that's another
We do
conversation.
have to be
I have to talk to
badged
her
in.
offline about that. Going in on the maternity unit to sit with moms who had just given birth. There is a theme here. And tonight, Pam shared her story. And I do want to give a call to action for people who are reaching out to us about starting these programs in their hospital is this. Start talking to more individuals who are pregnant, who are about to deliver, who have just delivered. Start talking to people. Start building these programs in your hospital systems on the stories of people. That's how we did it. We had to understand what people were going through. We had to listen to their stories, and then we grew from there. But it can't be on policies. It can't be on procedures. Like, try to move away from that. Reimbursement is important. We understand that, but start talking to people and reframe your motives, your initiatives, your great ideas around the people it will affect the most. Can we do that? You have anything to add?
I think you said it beautifully, but I will also just add that when you are trying to start a program, a team is important. And so when you are doing that, you may feel like you're the only one on the team initially. But when you go to the OBGYNs or the OB nurses, come at it from an angle of how can we work together to better serve our patients? Not, I want to do this to help the patient, not I can offer this, but what can we do? What can we do together? It's a more powerful way to not only get your foot in, but to also recognize that doing something fully on your own, it's really hard, it's really difficult. A team is really important. So don't forget about that either.
Awesome. Thank you, Dr. Seagraves.
Of course. Thanks for having me.